We'll be getting started momentarily. Well, hi, everyone. I'm Liz Whitehead, Managing Editor of Events at U.S. News and World Report. In today's webinar, we're exploring innovations in pediatric surgery, improving outcomes for children. Today's webinar is part of Transforming Pediatric Healthcare, a virtual event series from U.S. News, developed with support from Children's Health and its flagship hospital, Children's Medical Center, Dallas. You can learn more about today's speakers and all of our programs at usnews.com/events. We are recording video of today's session, as well as streaming on the U.S. News Facebook, LinkedIn, and YouTube channels. Now, I'd like to welcome our panel. With us today are Dr. Christopher K. Brewer, Director of the Center for Regenerative Medicine at Nationwide Children's Hospital, and Director of Tissue Engineering at The Ohio State University Wexner Medical Center's new Center for Regenerative Medicine and Cell-Based Therapies. Dr. Mary Brindle, Director of the Safe Surgery, Safe Systems Program at Ariadne Labs, as well as a Professor of Surgery and Community Health Sciences at the University of Calgary. Dr. Kenneth Gao, Attending Surgeon in the Division of Pediatric General and Thoracic Surgery at Seattle Children's Hospital, and past chair of the American Academy of Pediatrics Section on Surgery. Dr. Bradley Weprin, Director of the Division of Pediatric Neurosurgery at Children's Health, Professor of Neurological Surgery, Pediatrics, and Radiation Oncology, and Vice Chair of Quality Neurological Surgery with the University of Texas Southwestern Medical Center. Before we begin, one final note. We encourage audience questions and invite you to type them into the Q&A feature on your screen. Our moderator will try to give voice to some of these as time allows during the panel discussion. Now, I'll turn it over to Morgan Felchner, Executive Editor for News and Events at U.S. News, to lead the conversation. Morgan?
Thanks, Liz, and welcome to all of our panelists. No parent wants their child to have surgery, yet nearly 4 million children, adolescents, and teens have some sort of surgical procedure every year in the U.S. And as we all know, children aren't just little adults. They require specialized skill and training, and surgical errors can have tremendous consequences. So today, we're going to talk about innovations to make that scary time a little safer. Let's start with a broad question. Can someone please lay out at the highest level what the state of surgical care is for kids today? Dr. Brindle, would you like to start?
Yeah, I'd be happy to. So we are at a point, I think, right now where we're seeing a huge new capability in pediatric surgical care. We're seeing an influx of technology that is really occurring at a rate that we haven't seen in the past. And I think this has a lot to do with some of the new technologies that have got increasingly smaller, so we're able to use them in children. We haven't been able to use those before. We're seeing information technology evolve at a very rapid rate that changes a lot on how we communicate, how we care for patients out of hospital. And at the same time, I think that the patients that we're able to operate on are increasingly complex. We're seeing a lot more premature infants. So even though our capabilities are increasing, our risks are increasing as well. So it's really, I think, a critical moment for us to have this meeting and conversation today.
Let's dive a little bit more into that and turn to safety and quality. Dr. Weprin, can you tell us about your work at Children's Health to improve quality and safety for kids by reimagining the way a critical communication tool is used?
Sure. So let me first start by saying, surgery is a team sport. Technical prowess only gets you so far. And for effective, safe outcomes, you need to understand that there are a number of people that work together. And for a team to be successful, you've got to be able to communicate well. And surgery is played or performed, our arena or our pitch or our field or our stadium is the operating room. And the operating room of today is more and more complex and has challenges for communications. The operating rooms are set up and designed for multiple different types of procedures, increasing technology. There's a greater number of stakeholders, so more members of your team. And as the stakeholders are increasing, right now we're at a point, health force or workforce in healthcare is changing. And so the turnover is great. So in the operating room, trying to make sure that your team is completely aligned for one shared goal, and that's safe, effective surgical outcomes, requires, really, really good communication. And there are a number of different tools, checklists, debriefs, timeouts, and I think we'll hear about that in a little bit, all designed to improve communication, to make sure that everybody in the operating room, all of these stakeholders, share one specific goal, and that is to take care of that child. So there is one task or one activity, it's called a huddle. And a huddle is designed to standardize what's going to happen in that case between all team members. And huddles have been shown to improve outcome, improve efficiency, improve safety, improve overall care. The problem with huddles is you have to be compliant. It requires all the team members to be present. And at 7 o'clock or 7:15, when you're trying to get that case started at 7:30, all the different members of the surgical team are running around. They can't all meet to discuss, hey, this is what's going to happen in the case. Now, you could do that at the timeout. Problem is it may be too late. So a couple of years ago, huddles were introduced to the ORs here at Children's Health, and there was limited compliance. And so if no one's going to perform a huddle, you can't expect it to be successful, and you can't expect it to improve communications. And I won't get into how we came about, but we decided that huddles had to be asynchronous, had to be virtual, had to be patient specific or surgical discipline specific. What is important to a neurosurgeon may not be important to an orthopedic surgeon or a urologist or plastic surgeon. And it also needed to be able to be performed in under a minute, and it needed to occur before 7:15 or 7:30. And the only way to do that would be to digitize it. And lo and behold, I looked and found a startup. It's called Chiefy. And we partnered with this startup to introduce a tailored technological platform in neurosurgery. And we would, the attending surgeons the night before or even several days before would go into this web-based platform, go through their case. The system actually learns, so it knows your preferences. It discusses the exact case, all that you're going to need for that case, where the patient is going to go after that case. And then the nurse can sign on, the tech can sign on, the anesthesiologist can sign on once they've been assigned to that room. And so we've been doing this now for about 6 months. And we looked at pre-intervention and post-intervention, and we can show that surgical flow has dramatically improved. The number of interruptions during a case have dropped 8-fold. They've gone from an average of 9 interruptions or questions throughout a case to under 1. We can show cost benefit, efficiency benefit, and what's more important, we can show engagement. The nurses, the techs, the anesthesiologists love it. So that's a virtual huddle.
That's great. Another tool that I've heard of is a surgical safety checklist. Dr. Brindle, could you give us a little bit more information on that and what you're learning by fostering its use around the globe?
Yeah, absolutely. And this is something that we care about quite deeply at Ariadne Labs. Surgical safety checklist may be familiar to many of our listeners, but it's probably the most successful surgical safety tool in terms of its overall adoption across the globe. And I also believe in terms of its potential impact really across all settings. I was really excited to hear Dr. Weprin talk about surgery being a team sport and communication really being at the core of success. And the surgical safety checklist really recognizes that and hones in on that. It's a three-part communication tool, and it was developed by the WHO through the Global Patient Safety Challenge. There was a recognition of an unacceptably high burden of disease related to surgery, and Atul Gawande and his team came up with this idea of a checklist to address that. And the checklist lightens the cognitive burden placed on surgical team members, so it helps us focus on the process measures that have to be taken. But even more importantly, it provides us opportunity for people to share information and to have that same kind of shared understanding that Dr. Weprin just talked about that you can also gain from a huddle. But the checklist itself, it's a tool. It's not a drug. So the way it's used and who uses it, how they use it, is really critically important in how well it works. So the effectiveness of the checklist is really directly related to how well programs have learned how to implement it. And we've certainly seen that there's almost a dose response effect in terms of how well people create systems around the use of these tools like the checklist, and how effective it is at reducing things such as perioperative mortality. And one of the things that you asked about was its effectiveness in the globe and across the globe, and how we have helped programs use it when interest is flagging. And I think a great example of that comes from the work we did in Singapore. So Singapore General Hospital, a huge hospital, does about 92,000 cases a year, highly efficient, really a very good performing center. But they recognized that there was an ongoing and persistent incidence of safety events that would just keep occurring every month, every quarter. And they decided that they really wanted to change that. At the same time, they also recognized that they were increasingly introducing new technologies into the OR, and teams were having to learn these and adapt to these. And there were interruptions that would be related to the introduction of these devices. So we worked with them and developed a device briefing tool, but we also helped reinvigorate the checklist. So looking at it with them and understanding how we can understand and how we can look at it and say, in what ways can we actually improve engagement? In what ways can we make this checklist actually be meaningful to the users so that they actually value it, appreciate it, and want to use it? And it was really dramatic what we were able to see in terms of some of those outcomes related to communication, to teamwork, but also really importantly for them is that we saw device-related interruptions drop dramatically, and those safety events almost disappeared. The ones that they were seeing on this monthly basis, like almost vanished, really just through good team communication. I think that's one of the things that the checklist can really do.
That sounds fantastic, and communication is clearly important. Let's sort of broaden a little bit again and talk a bit about some of the obstacles that maybe some of this communication is helping with. So Dr. Gao, you have a national perspective on some of the major challenges pediatric surgeons experience today. What is the biggest obstacle you and your colleagues around the country face now, that maybe the problem you most urgently need addressed?
Sure. Thank you, Morgan. And I'd like to echo and applaud all my colleagues who are on this webinar about their perspectives. Totally agree that this is a team sport, and that where we are right now is actually a really unique time in our lives where safety is really looked at. But I'd like to point out that we're all still living in the post-COVID era. And one of the challenges that I think we've all dealt with and still dealing with is in our ability to get the tools that we need to actually do the work that really need to do on a daily basis. This loss of the supply chain has really uncovered a lot of the challenges that we have in order to get the tools that we need to use on a daily basis. But I'll also echo that as pediatric surgeons, we all vitally need the tools to do our work on every single case. And in many situations, the tools that we have available have in fact not been created for that purpose. We often end up using tools that have been created for other purposes, and we essentially reuse it for different other tasks. And really the creation of new tools and tools for us to use is something that I would like to point out is a big challenge for many of us. Some of us who have the opportunities to be aligned with universities have the chance to actually work with engineers and being able to help identify the problems and identify solutions to those problems by creating the tools that can be used and sent out to our colleagues around the world to be able to be utilized.
Dr. Brewer, take us into your world of innovation and translational research. What are you working on now, and how could it be a game changer for kids?
Sure. Thank you for your question. So early on in my training, I realized I love being a surgeon. It's wonderful when a patient or a family comes to you with a child with a problem and you can fix it. But it was equally distressing to have parents come to you and try to help their child with problems that we didn't have solutions for. So I decided to devote a lot of my career to what's called translational research, or how we go to the laboratory and try and find answers to the questions that we currently don't have answers for. I work in a field called tissue engineering or regenerative medicine. And this is a field that tries to take advantage of the fact that our own cells have the ability to multiply and then self-organize into functional units. And the reason why we use tissue engineering in surgery is because on a daily basis in the operating room, we're constantly removing tissues that are either diseased or damaged, or trying to repair tissues or replace tissues that are congenitally absent. And the paucity of tissue that we have to do these reconstructive operations really limits what we can do. One example of a solution to this is the field of transplantation, where if an organ goes bad, you replace it with a new one. And that's great, but it suffers from two really significant problems. One is donor organ scarcity. There simply aren't enough organs to go around. And two, anybody that has a transplantation requires immunosuppression, which really trades one problem for another. So I've been working in the field of tissue engineering, trying to develop biodegradable scaffolds that can help your body regenerate cardiovascular tissues. And specifically, we're working on making blood vessels, heart valves, and patches that can be used in congenital heart surgery to repair or replace missing pieces in children undergoing congenital heart operations. And the advantage of this approach is that the tissues are alive, and so they have the ability to repair, remodel, and even grow, which is a fundamental problem that we face in pediatric surgery all the time. Whenever you have to use a man-made replacement part, or replacement heart valve, a blood vessel, vascular graft, the patient can have a life-saving operation only to outgrow it and need additional surgeries and incur additional risks. So we're trying to use tissue engineering techniques to overcome this basic problem.
I want to dive deeper into innovation, but first, I understand this journey has been over 25 years in the making for you, involving a 3,000-word document that took 6 years to write. What kept you going?
Well, I think that there's really two things that kept me going. I think these problems are fundamental. They're there every day, and if you can't just do nothing about them. But then two was the progress that we've made. So we've been able to take this technology from the bench to the bedside, which has been really exciting. And anytime there have been setbacks in our clinical work, I've been able to look to the preclinical work to see how much progress we've made, and the fact that we actually can grow vessels, and the fact that we actually can grow cardiovascular tissues that can be used in operations.
No, thank you. Let's talk a little bit more about the innovations like this. So Dr. Weprin or Dr. Gao, what are your perspectives on the intersection of innovation and safety in neurosurgery and beyond?
I think that we're in very exciting times, and you are seeing innovations occur at an exponential pace. In terms of the intersection, though, I think we have to clearly evaluate how safe these innovations are, how effective they are before they're taken to the clinical realm. It's exciting. We can do things now that we weren't able to do when I first started. I have a colleague who is a pediatric neurosurgeon, but also an interventional neuroradiologist. He can do things with catheters that I was doing open surgery for. So it's exciting. I think we need to always keep in mind, we need to maintain a culture of safety and efficacy in whatever innovation, whether it be technological, whether it be programmatic development, but whatever we're doing. So if we're innovating, it comes without saying that it needs to be safe.
Yeah, I'll jump in and say, and totally agree. I think that it's a fine line. Obviously, everyone wants to have the new, shiny, newfangled tool, and that's something that we all like to have. But we also need to look at how that's going to benefit the child. benefit the patient and make sure that it ultimately does what it's supposed to be doing. There's obviously many different layers and rules that we all have to get through in order to make sure that various instruments and tools that are developed do what they say they're supposed to do. And we need to make sure that we always keep track of what's happening with any complications that might arise, and make sure that if that happens, that we look to see and how to improve things. Unfortunately, most hospitals have systems of review where these items keep being looked at and tracked. And we need to always be vigilant to make sure that the tools are being used in the right way as well. So education is also something that's really important to make sure that people that are taking new tools on and taking new procedures on are doing it in the right way. This may mean going to courses. It may mean being mentored. It may mean having other individuals who are more proficient in certain tools stand and operate side by side with you. But ultimately, what we need to do is make sure that whatever we do that's new is done so in a safe fashion.
Dr. Brindle, any insights from your research examining how devices and innovative tools can be introduced safely?
Yeah, no, I think it's a really good question. It comes back to this idea of the importance of seeing a tool as just being part of how we care for patients. So that if you're looking at introducing a new tool into a program, that there's a lot that goes into that in terms of, some of the technical aspects of understanding its safety, but also making sure that the teams that are using these tools have a really good understanding of where they fit into good practice, and so that the teams are educated, that they have a good understanding of it, and that when they're using these tools in a rare circumstance, that everyone comes to it with a shared understanding. And one of the other areas that we always have to think a little bit about is as we develop higher, more complex technology, it's less and less available to the general population. So we have to think a little bit as well about where are the sites that we use it and who are the beneficiaries and who perhaps are the people who may suffer if these tools aren't available to them. So a lot of things I think that we have to think about when we start introducing new technology, but they're exciting challenges, I think, for all of us.
Absolutely. I'm going to shift us a little bit. So Dr. Brindle, I'll stay with you for a moment. You've been innovating in a different way by bringing enhanced recovery after surgery approaches to the neonatal area. Can you describe what you're exploring and what you're discovering there?
Yeah, no, absolutely. I think the neonatal population really represents, I think, some of our most extreme challenges. These are patients that are highest risk patients. They have mortality rates and rates of complications that are much higher than most of the populations that we deal with. And their issues are often very, very rare or even unique. So trying to understand how we deal with all of these rare circumstances, high risk patient population. One of the things that enhanced recovery after surgery protocols allow us to do is allows us to create teams that can kind of think most effectively around these complex surgical cases. So many surgeons will be familiar with enhanced recovery after surgery. It's been around for a couple of decades. It's really had its origins early on in colorectal surgery, but it's expanded really across pretty much every surgical sphere. And they're really multimodal, multi-professional, evidence-based guidelines and pathways that are aimed to improve outcomes through targeting a number of different physiological aspects as well as communication. So pretty complex and very effective when they're used particularly well. One area that has been a little bit slow in coming along is pediatric surgery, and neonatal surgery, really up until recently, wasn't even on the table for enhanced recovery after surgery. But it is, I think, really a unique environment that can really thrive with ERAS because we have this physically defined space for a lot of our patients who are neonatal patients. And we also often have a degree of consistency in the teams that look after them. So we actually have this perfect and fertile environment for using these kind of team-based strategies to improve care. So we've been developing a unit-based approach to enhanced recovery after surgery, where we work with all of these various teams that care for neonatal patients and really try and standardize where we can appropriate surgical management and allow for some tailoring. I think a great example of what is possible is that in our site, in many sites, there was a belief, or there is a belief in other places, that every neonate needs to have a lot of narcotics, both during the surgery and after the surgery. And there's just an expectation they're going to be ventilated for many days because of this narcotic need. And the use of some of these ERAS protocols has allowed us to recognize that there are these pathways that use all sorts of different ways of managing pain that allow us to use almost no narcotics to get children off a ventilator really early. It's one of the few areas in enhanced recovery after surgery where we've actually found units have put themselves forward and saying, we really want to do this. We really see these opportunities. And it's hard when you're actually putting work onto people, and you actually find that there's groups that are interested in doing it. I think you know that you're hitting on something. So that's sort of where we're at right now. It's very exciting.
So let's talk a little bit about hospitals and health system leaders and what they can do to promote a culture of innovation, quality, and safety in pediatric surgery. Dr. Brewer, would you like to start?
Sure. At least from the perspective of translational research, the hospital is absolutely essential in order to do anything of this nature. And if we're really going to advance the fields, translational research will be essential. It's very, very expensive to do translational research. If you're getting your MBA, the first lesson they teach is it's $1 billion to develop a new drug, to go from an idea to a new product. Part of the reasons for that have to do with the fact that drug companies' primary motive is to make money. They do want to take care of patients, they do want to do a good job, but that really inflates some of these costs. In fact, I think a lot of translational research, first-in-man studies, early clinical trials can be done very well in academia for a much lower cost and can therefore accelerate the development and implementation of these things. But again, it requires a lot of infrastructure. You need things like regulatory support. You need things like clean rooms in order to do some of this sort of work. And you need a culture that supports this sort of stuff.
Dr. Gao, any thoughts from your national vantage point?
Sure. I think and I totally agree with Dr. Brewer's assessment. I think that where hospital leaders and healthcare systems need to look at this is something where I think is happening perhaps organically, but is really the concept of subspecialization and the creation of things such as centers of excellence. And so what I will take as an example is that if a center has specific leaders in certain clinical areas, I'll just make this up, colorectal surgery, for example, and you're able to create a team around that particular area of expertise. By building that team and having folks that do certain things over and over again on multiple different challenging patients, you can essentially condense your area of expertise. And thereby, you essentially build in the quality because of repetition. And by doing this, you're also able to, from a financial standpoint, pull in other experts who are able to add to this entire delivery of care. And by having these centers of excellence in various different parts of the country, patients across the country can look to these centers that are perhaps closer to them in order to get some of these highly, highly sophisticated areas of care that is necessary. And thereby having this center of excellence, you're able to condense care, you're able to hopefully keep costs down, and you're able to have patients from across the country get excellent care. And so I think that from an overall perspective, things have really been really revolutionary. I've been in practice for 2 decades now, and I can tell you when I started compared to where I'm doing now, we have changed things drastically in terms of going from pediatric surgeons that essentially do every single case now to almost every pediatric surgeon in tertiary and quaternary care centers, essentially having 1 or 2 really main focus areas that they do really, really well. And again, it is a team sport, but you're able to work with a bunch of people that really are focused on certain areas. So I think that's something that has really changed, and I think has really helped patient care.
Dr. Weprin, any thoughts from your side about what hospital systems and leaders need to do?
So I am in complete agreement with everything that I've heard. And the cost of developing the infrastructure to provide the resources is extremely important, and obviously frontline, right? You can't do it without being able to provide that. But what I believe the leadership, whether it's physician leadership or hospital administration leadership, can do is to get out there actually and do it, right? Engage. They need to engage the frontline employees. So you can't just pay for culture. You can't just incentivize for culture. You have to practice it, and you have to hire the right people, put them in the right places. But I believe it really takes the frontline personnel to care as much as the surgeon, as much as the anesthesiologist. People are good people. No one wants to do anything bad. Everybody wants to do things good and wants to do good for their patient. And so I believe that leadership needs to provide the frontline workers the resources with which to be able to do those things. And that may be time, that may be, you're going to have to pay people to come in at different hours to be able to improve their education, all sorts of different things.
Dr. Brindle, I see you nodding and smiling. Do you want to add anything?
I agree with everything that was just said. I mean, building culture requires intention. You can't just allow it to occur passively, and maintaining culture, I think, requires the same degree of intention. I think historically people felt that programs lived or failed because of a pre-existing culture, and that there was really no point in trying to implement or improve things if your culture was less than optimal. But I think we're learning more and more that leaders can build good culture. And yes, it helps to have something good to start with, but that really that recognition that investing in both some of the things that have been talked about before, which is allowing the frontline individuals to identify projects that are critically important to them and providing support for them to build them, but even just globally to role model that investment in building culture, I think is really critical. So I was really excited to hear what the other folks said, because I agree with every single thing.
That's great. Let's shift back a little bit towards innovation. And Dr. Brewer, I want to ask you a little bit more about your research. So you have deep experience in the realm of what it takes to fund innovation and translational research. Help us understand that piece of your work. How much does translational research cost, and why do so many projects fail?
Yeah. So again, if we go back to what they teach you in business school, most projects do fail when companies are trying to make drugs or devices. And I think a part of that reason comes back to their philosophy. Sometimes they're looking for the biggest market to make the biggest profit, and there's a saying they want to fail early. So there's not a lot of room for incremental improvement. I think with the pressures of making money off in the academic arena, you can take a different approach, which particularly in the case of children and rare diseases, can enable you to get products to the market quicker, more safely, and more cost effectively. One change that has really facilitated progress in the area were some legal changes in the development of what are called the orphan regulatory pathway. If you look at the physician's desk reference, which is the book that has every drug, less than half of the drugs have ever been tested in children. And so the doctors are using these drugs off label. And the reason for that is because there's a major financial disincentive to the companies to sort of support this sort of research. If you have a successful product and you're making a lot of money in a big market, you don't want to test it in a small market and potentially have an unanticipated adverse event occur that takes your drug off the market or takes your device off the market. So what the orphan regulatory pathway does is it incentivizes people to work in these sort of orphan fields, and particularly in the pediatric market. And I think that there's been some real successes due to that. So they sort of changed the equation, which makes the work which makes the work less expensive, but enables you to focus in on these, which therefore enables you to focus in on these rarer diseases.
I'm sensing a bit of a theme here. Dr. Gao, you talked earlier about how there's a dearth of surgical devices that are sized for pediatric patients, and that sounds fairly similar to what Dr. Brewer here is talking about with the drugs. Dr. Gao, can you talk a little bit about ways surgeons themselves can close gaps by partnering with bioengineers or other techniques that you're employing to try to close this gap?
Sure. I alluded to it earlier, and I would encourage anyone who's watching this webinar and who have had the chance to actually be within a center that has partnerships with our bioengineering colleagues. And I'm in Seattle, and I have the opportunity to work with great engineers at the University of Washington, for example. And they've set up programs which I think are similar to many other places across the country, whereby they seek problems, clinical problems, and they partner the clinicians with engineers. And by having the direct input from clinicians who feed in to the engineers what the challenges are that we see from a daily basis, our engineers, who are really bright and talented, can start thinking, utilizing their skills, and essentially creating the solutions in partnership with the clinicians to figure out what's the best solution for the problem at hand. And these can sometimes result in spin-off companies. I know that there are several companies that have formed through the University of Washington that essentially are a single device company. Sometimes these go on and make large amounts of money. Sometimes they get bought over, but ultimately they benefit patients. And so what I would encourage people to think about are the problems that they see on a daily basis, what challenges you see, and what ultimately needs to be fixed. Talk to some of the engineers that you may know, and then ultimately you may actually come up with a device with your engineers that may solve the problem. I've had the great fortune to work with several engineers, and we've come up with several devices, some of which have been patented, some of which are currently going through trial. One device that's currently going through things is a type of tape adhesive that we're currently testing, which is applied and released through different temperatures. And for children, this is important because kids have thinner skins, they're more fragile. And so we looked at this as being a problem, and the solution is hopefully coming to the market soon. And so these small examples are ones that I would hope that the people watching this will feel that's something they can do themselves. In other words, you know the problem. Let's help find the solution.
Dr. Weprin, do you have any thoughts on solving some of these problems?
So, I mean, we are currently doing that. I think some of it is so as Dr. Gao was mentioning, looking at the difference between pediatric patients and adult patients, right? So in a lot of neurosurgical procedures, you're operating on the brain, and it requires us to hold the head still. Well, the skull in a baby is very different than a skull in a teenager and an adult. And how do you deal with that? And you could say, well, we've been doing that for 75, 100 years, but I have a partner who's working with engineers and in the process of creating a head holder that it doesn't necessarily matter whether you're a baby or an adult. I have another partner who is trying to look at non-invasive ways of evaluating the pressure inside of your brain, whether that be in cases of trauma or whether that be in cases of something called hydrocephalus, which is the most common disorder we treat. But trying to do things in a less invasive way.
It's remarkable to me that something as basic as a head holding device isn't appropriately sized in 2023. So I'm glad that we're here to shine a light on this and to talk about it a bit more. Dr. Brindle, do you have any thoughts on this?
I guess one of the things that I reflect on a little bit when we chat about this is that surgical disease is a disease that is not restricted to settings where there is a huge number of resources and it's not all at the sort of highly refined and highly technical hospitals. That this occurs all over the place, and there's opportunities for us to innovate within all of these different settings. So one of the things that I think is always good for us to be aware of is that some of these low resource settings that deal with pediatric surgical patients and pediatric surgical complications are also great opportunities for us to explore innovation. Even some of the things that we're being chatted about, like such as the surgical dressings and what have you, have huge amount of opportunity in some of these places where people don't traditionally look to develop and implement and study. So I just put that out there as one of these opportunities that I think we often overlook.
And I'd love to expand a bit on what you touched on earlier in the conversation. You focused a lot on making sure new devices and innovations are introduced safely. How do we do this, balancing innovation with quality and safety?
Yeah, I mean, I think it's really important. And I think those of us who did training, for example, in general surgery at a time when laparoscopic surgery was still relatively new, and you're having to contemplate the risks of the surgical procedure where people are just learning how to do it, with what you perceive as being a tremendously valuable and important contribution to how surgical care is performed. I think those things are difficult. One of the things that I think helps is having a robust system around that doesn't rely on some of our traditional ideas of the single surgeon going out there and doing a case and seeing themselves as not part of a team, and not having that input of people around them who are a second set of eyes or a second way of looking at things, and introducing things, I think, in a way where you have perhaps two surgeons who are working when there's a new device being introduced, so that you have two different viewpoints on it, where there's very clear communication with family members, so that people understand when there's a new surgical technique or device being introduced. I think there's a number of safety measures that we can very safely put around these procedures. And I think a lot of parents and children enjoy being part of a process where innovation is occurring, as long as they feel that those teams that are bringing these in have a strategy to make them as safe as possible, so that communication is there, so that people have been taught around them, so that there's backups and safety mechanisms, and that it doesn't feel as risky, and it doesn't necessarily have to be as risky.
Thank you. Dr. Weprin, let's revisit your work to improve communication and teamwork. I know you have a story that you told us, at least, and hopefully you'll share it with our audience, about zero shunt infections. So what universal lesson does this hold for us, and how other teams can make surgery safer for kids?
So I think as a pediatric neurosurgeon, right, the holy grail is something called a zero shunt infection. And so shunts are devices used to treat something called hydrocephalus, which I just mentioned. It's the most common disorder pediatric neurosurgeon treats, and shunt is probably the most common procedure a neurosurgeon does. And it's technically not that difficult. The problem is it's fraught with a lot of problems. It's a man-made device, and everything that we make is prone to fail or prone to get infected. And if a shunt gets infected, it causes significant distress to a family. It's hospitalization of a couple of weeks, being on IV antibiotics until the infection clears and before hardware can go back in. Also, if a shunt gets infected and it infects your brain, we know that has significant impact on cognitive performance later on. So trying to reduce the rate of shunt infections is extremely important amongst neurosurgeons. And I remember reading years ago a paper out of France saying how they had gotten 0 shunt infections. And I didn't ever think it was achievable. But in 2021, we did have 0 shunt infections with close to 200 shunt procedures being performed. And I will also say that the 5 years before that, our shunt infection rate was around 0.6%. So it's very, very low. And we got there not because the surgeons are technical giants and we're doing things different or better than anybody else, but we have a culture of teamwork that looks at doing things better. And that has changed our processes, our preoperative processes, our intraoperative processes, and our postoperative processes. We have, and this is an iterative process, so it's taken 15 years. And the other question is it sustainable? And I will be honest, in 2022, we were back up with a few shunt infections, still not high, but we didn't have 0. And there's some reasons for that. But we were able to achieve 0 shunt infections in a year, again, because of the team that I work with. We reduced variability. All our decisions were guided by evidence-based results, and it was collaboration between providers, between nurses, between techs, and between nurses on the floor. I can't say any more than that.
So teamwork has been a common theme. We keep going back to it. One thing that I think requires the teamwork of everybody, including me and all of you guys here, is health equity. While not necessarily directly related to surgery, it's something that is really permeating the medical world. It's comes up again and again. So I wonder if any of you have thoughts on how we can better ensure that high quality surgical care and the innovations that we're discussing are accessible to all kids.
I think from the perspective of developing and testing new technologies, it's critical that your patient population that you do the tests on reflect the demographics of the general population. And I think the FDA has done a great job of ensuring that's the case.
Yeah, maybe I'll touch on that briefly and say that earlier I talked about the centers of excellence and how that was an important aspect of improving specialized care. The challenge with that, of course, is most centers of excellence end up in larger urban centers, and much of the population, about 1/5 of the population in the United States, for example, live in rural areas. And so we need to make sure that whenever we create new centers or new ways of doing things, that we make sure that this is accessible to everyone. And if you live in areas that are further away, we have to make sure that it's accessible to them as well. And it's a challenge. And it's something that we need to keep our eye on the ball to make sure that every child across North America get access to the very best care that is accessible at that time. It's not easy, but we need to make sure that that happens.
Let's move a little bit more back to the big picture again. So I wonder if everybody could weigh in on what the future of pediatric surgery looks like. How do we move the field forward to improve outcomes for more children? And beyond what Dr. Gao highlighted earlier in the discussion, what's standing in the way of doing that? So a lot of different questions there. Hopefully we'll get some robust discussion.
I'm happy to jump at that first, simply because I really agree with what Dr. Gao was saying. And I actually feel that provides a bit of a foundation for what we'd be thinking of in the future. These hubs of innovation and excellence, but also much greater connectivity with the other sites that are more sort of geographically dispersed or poorly resourced. And I think that this ability to innovate aggressively, but also safely, and to share those learnings broadly, so that we're aware of those potential issues with equity, but we also have these this interconnected ability to collaborate and work together. We're at a stage now, I mean, in some respects, COVID really helped us with this. We are expecting now to be at a geographic distance for many of the colleagues that we work with closely every day. And I think that we're at a stage right now where innovations can be shared in a similar way. Team-based innovations is one great example, but even some of these technical innovations that can be introduced safely, where there's an opportunity, for example, to be in the same OR with someone who is hundreds of miles away. I think there are real opportunities for connectivity that I think I'm hoping that we're going to be seeing introduced in the next several years.
Dr. Brewer, any thoughts on what the future of pediatric surgery looks like?
Yeah, I think from a translational perspective, I'm very excited about the notion of fetal regenerative medicine. So, the fetus is hardwired to regenerate, and it's an ideal environment for trying to do tissue engineering. And due to the plasticity of the fetus, small structural corrections that are performed in utero can wind up having much more dramatic downstream effects. So, for example, we're working on a way to replace fetal heart valves with tissue engineered heart valves. And what's exciting about this is in developmental biology, with regard to the heart, they say no flow, no grow. So a lot of times a valvular defect can not only affect the valve, but the formation of the entire ventricle, which has much more significant implications and bad downstream problems. And so by replacing it in the fetal environment, you can actually eliminate the problem.
That's great. We do have one question from the audience that I'd like to give voice to. So this person is asking about post-procedure early ambulation. So in the adult world, post-procedure early ambulation has been implemented and credited as one of the initiatives that have helped positively impact patient outcomes. I have seen post-procedure early ambulation leveraged in the pediatric world, but not as prominently as we do with adults. First, can we start by explaining what post-procedure early ambulation is for those of us who might not know, and what role it plays to improve outcomes for the pediatric population? Dr. Brindle, you're muted.
So sorry. I think that does fall a little bit under the ERAS heading, so I'm happy to tackle that first. I guess one of the first things I'd say is, so early ambulation is kind of exactly as it sounds. When patients have had surgery, there used to be an expectation that you would have this prolonged period of bed rest that could last many, many days. And there was a feeling that getting up could cause harm to your healing or disrupt incisions. So people were staying in bed for a long period of time. Now, I will say that the elderly population has suffered significantly with that method of care. And so they're probably the population that most benefits from this. But I think what it touches on is rehabilitation in general and what that means. So partly, yes, getting out of bed and building muscles is important for all age ranges. But I also think there's elements of rehabilitation that are specific to kids that we often don't think about. There's social rehabilitation. What does it mean for an adolescent who has a prolonged recovery and is missing out on important educational and social phenomenon? There's feeding. That is a critical skill that occurs and develops at a specific time point in early infant developing. How do you rehabilitate a child physically so that they don't develop what we call oral aversion, or this desire not to eat because they haven't figured that out yet? There is parental bonding. That's an important part of rehabilitation as well. So there are social, psychological, and physical rehabilitation elements. It's very common for us to see that children miss some of these early developmental milestones. And many times they catch up, but there are many impacts that are hard for us to be aware of. So ambulation, certainly in the adult sphere, is important. In the child sphere, probably important. But I think many of these other rehabilitation measures are equally important.
Thank you. We have about 6 minutes left, and I want to make sure that everybody gets a chance to give their final words and final thoughts. If there's anything that we didn't cover that you want to share, but also just any thoughts on the future of pediatric surgery. Dr. Weprin, can we start with you?
Sure. So thank you for having us. I guess, in terms of where I see the future going, right? And I don't know that it will ever happen, but the goal is to put the pediatric surgeons and specialists out of business, right? We're trying to do things so that we don't need to operate and we don't need to do surgery. And so that's probably where innovation is going. I think we will still never be completely out of business, but I'm excited that many of the things that I was doing 20 plus years ago, we're not doing anymore because they can be done better with medicine or with things other than surgery. And I see that only increasing, which is a good thing.
That's great. Here's to putting you guys out of business. I appreciate that. Dr. Gao?
Sure, I'll echo that and say that a lot of things that we're doing now is totally different than when I learned it as a trainee. And that really tells me that a surgeon who is working today must have an open mind in order to understand that there are new ways of doing things and to be receptive of possibilities that that a method can be improved upon, and constantly challenge yourself to consider how to do things better. And it may be small changes, it may be major changes, but as long as you constantly evolve and try to make things better, I think that's where I think I have the hope for the future. And each time I go to meetings like the AP or APSA and seeing our young trainees who are doing research present their work, I am astonished every single time that I see them present that there are totally new ways of looking at things. And so I would really encourage everyone just essentially to keep an open mind, understand that there are new ways of doing things, and roll with things as they get presented.
Always changing, it's an important thing. Dr. Brewer, any thoughts?
Yeah, I'd just reiterate that same point. Never be satisfied. The children are so important. It's our most valuable resource, and never be satisfied. Constantly push the envelope and see what we can do to make tomorrow better.
I agree with that too. And Dr. Brindle.
Yeah, I would just echo the thoughts of my colleagues. And I'd also say that an opportunity like this, where you are able to bring together people who have all sorts of different approaches to the same problems and are able to share them and think about common concerns and complications from totally different angles, I think is a wonderful way to pursue the problems that we're going to be continuing to see in the future.
Thank you. I think it's been a wonderful discussion, and hopefully the audience took as much from it as I did. I thank you all for being here with us today. That's all the time we have. Thank you to the panelists and the audience for joining us for this important conversation. To learn more about pediatric healthcare, check out our coverage at usnews.com or tune into another webinar at usnews.com/events. Goodbye for now.
Thank you for this opportunity.
Thank you.
Thank you.
Thank you.